I know where people are going to show up late, but we want to respect our speaker's time. And so I'm going to give a quick introduction to Lydia Roper. She graduated in 1992 with her master's in social work and has been a licensed clinical social worker since 1985.
Graduated in 82, but thanks for the added years.
Sorry.
That's all right.
Prior to joining SHARP, Lydia worked as a medical social worker in maternal child health at UCSD. Lydia has also been a member of the trauma committee at SHARP Memorial Hospital since 2009 and has worked on a number of projects, including but not limited to assessment and education around suicide, domestic violence, labor and sex trafficking, and trauma-informed care. And I'm going to allow Lydia to introduce Amanda, who worked on this PowerPoint with her.
I'd like to welcome Amanda Berry. Amanda waves so we know who you are. She assisted in the development of this learning module and is a recent graduate with her MSW and MPH from San Diego State University and is assistant to County Supervisor Tara Lawson-Reamer, District 3. So thank you, Amanda, for joining me today. Our talk today is on trauma-informed care, and this learning module was developed specifically for SHARP healthcare social workers. And I also took it to our nursing administration, and they have also indicated that this will be useful in orientation of new nurses. So I'm very pleased to present this program. This was actually initiated, as I said, to educate new staff, new social work staff in our department on trauma-informed care, and also was kind of a response to a talk that I gave along with a couple of other people on disruptive patient behavior and really looking at what the etiology of some of that is and what differential diagnosis might be. So the goal was for medical social work best practice includes asking about past traumas. And this module is developed to build awareness and competency in trauma-informed care. So the objectives are to define trauma. Can everyone see my screen?
Not yet.
Not yet.
How about now?
Yes.
Yep.
Okay, thank you. So the objectives are to define trauma and trauma-informed care, realize the impact of trauma during childhood on health outcomes, describe universal trauma precautions compared to trauma-specific care, identify the principles of trauma-informed care, understand how the SHARP experience relates to trauma-informed best practices, and identifying your role in trauma-informed care. The 4 R's of trauma-informed care are first realizing the widespread impact of trauma and understand the potential paths for recovery, recognizing the signs and symptoms of trauma in clients, families, staff, and others involved within the system, respond by fully integrating knowledge about trauma into policies, procedures, and practices, which is what we're working on at SHARP, and resisting re-traumatization of children as well as the adults who care for them. What is trauma? Trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning, physical, social, emotional, and spiritual well-being. It is normal to experience trauma across the lifespan and typically does not result in long-term impairment. Often individuals, families, and communities respond with resilience. So people can have positive stress, the body's normal and healthy stress response to a tense situation event, for example, the first day of school or work. There's tolerable stress, the activation of the body's stress response to a long-lasting or severe situation or event. For example, a loss of family member, but supportive buffers in place. And toxic stress, prolonged activation of body stress response to the frequent, intense situations and events. Witnessing domestic violence, for example, in the home, and chronic neglect could be an example of that. So trauma examples, we've experienced trauma in our lives, maybe something that was caused naturally, fires, earthquakes, some of the other things happening in California, water shortages, but even, something like hearing from a distance, a tornado has happened in a hometown, and that can be traumatic for the person. We're also looking at trauma caused by people, accidents, and technological catastrophes. For example, an aircraft crash, which we experienced here in the 70s in San Diego, an oil spill most recently up our California coast, maybe a gun shooting. There could be intentional acts of arson and terrorism, domestic violence, human trafficking, school violence, torture, to name a few. So it can be a single event, it could be a developmental trauma, happened over periods of time. Multiple events could have occurred. Relational, historical trauma, or war combat trauma could be part of that picture. So understanding the population and demographics is important. For that single event, a trauma can be a one-time or an isolated event, as in a car accident. Developmental trauma, as we mentioned, may be physical, sexual, and emotional abuse while a minor, as well as neglect. It can also involve witnessing violence between caregivers. Multiple events may have occurred, a series of difficult life events that interfere with healthy attachment in relationships and threaten the development in the following life domains: emotional, cognitive, language, intimacy, physical, and/or social. It could be relational or historical trauma, defined as a collective complex trauma inflicted on a group of people who share a specific group identity or affiliation. And war combat trauma. For some people, they are born into a culture where war is a part of their daily existence, and others are sent into war as military personnel contractors. The prevalence of trauma is common among adults and children in social service systems. 98% of female offenders have experienced trauma, often interpersonal trauma and domestic violence. 96% of adolescent psychiatric inpatients have histories of exposure to trauma. 93% of homeless mothers have a lifetime history of interpersonal trauma. 90% of juvenile justice involved youth have experienced trauma, often multiple traumas from an early age. And 75% of adults in substance abuse treatment reports histories of traumas. 70% of children in foster care have experienced multiple traumas, and the resources down below. The impact of trauma: feeling unsafe, low self-esteem, lack of trust, hopelessness, acting out behaviors. This is where the disruptive behavior came in. And can you think of how this is seen in our patients? We see this every day when we interview patients. So you can see that there are adverse childhood experiences in ACEs. The adverse childhood experience of abuse, physical, emotional, sexual, neglect, physical and emotional, household dysfunction with mental illness, incarcerated relatives, mother treated violently, substance abuse, and divorce. The ACEs questionnaire is a tool that is used often to help patients identify their risk categories. And just to read a few, did you feel that you didn't have enough to eat as you were growing up, had to wear dirty clothes, or had no one to protect or take care of you? Sometimes when we go into a patient room and we interview them and hear some of their histories, we hear these stories of neglect or abuse growing up, that they grew up with a mother who was in bed when they left in the morning to go to school and still in bed when they got home at night. Another question might be, did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? Did you feel that no one in your family loved you or thought you were special? So these are all questions in the ACEs Aware questionnaire that for adults that can be really valuable information in helping to identify those at risk. So long-term effects of trauma on health is what this is all about, right? So compared to people with no ACEs, individuals with an ACE score of 4+ were 2 times more likely to smoke, 2.5 times more likely to have sexually transmitted infections, more likely to have chronic obstructive pulmonary disease, 7 times more likely to consider themselves an alcoholic, 10 times as likely to have injected street drugs, and 12 times as likely to have attempted suicide. We see these in our patients every day. So recognizing the signs and symptoms. Trauma can impact every aspect of a person's life and show up in very unique ways. It can show up physically in unexplained chronic pain or numbness, stress-related conditions such as chronic fatigue syndrome, headaches, sleep problems, breathing problems, digestive problems. They can show up in emotional and cognitive behaviors, depression and anxiety and anger management, compulsive behaviors, difficulty concentrating, fearfulness, emotionally numb, suicidal thoughts and feelings of shame and guilt. Could be spiritual, loss of meaning of faith or loss of connection to self, family, culture, community, nature, a higher power, and feel completely different from others with no sense of connection. Could be interpersonal, frequent conflict in relationships, lack of trust, difficulty establishing and maintaining close relationships, experiences of re-victimization, and difficulty setting boundaries. Could be behavioral, substance use, difficulty enjoying time with family and friends, avoiding specific places, people, situations. Disordered eating could be part of the picture, and self-harm. Also very high risk for sexual behavior. So what is trauma-informed care? Trauma-informed care recognizes and responds to the signs, symptoms, and potential consequences of trauma to better support the health needs of patients who have experienced ACEs and toxic stress. So we're shifting our perspective from what's wrong with you, step back from our immediate reaction, and instead ask a more empathetic question to what has happened to you. Ask questions and gather a comprehensive patient history. Move one step further towards a strengths-based approach and ask what is going right with you. Amanda, trauma.
Okay, great. Can you all hear me okay?
Mm-hmm.
Okay, great. So this trauma-informed care pyramid, and if you look in the top left, you see the different guiding principles that we're following, and this is in the respond. And so when you look at this pyramid, what levels do you think are part of the universal trauma precautions versus trauma-specific care? They're different. So if you click the right arrow and get to the next animation, you can see that the bottom two are understanding the health effects of trauma. But if you click the right arrow, there it goes. Okay, universal trauma precautions are the bottom two, and those are things that that you want to do as a clinician, no matter what, whether you know that somebody has a trauma history or not. You need to understand the health effects of trauma and use patient-centered communication skills. The top three are trauma-specific care practices, collaboration and understanding your professional role, understanding your own history, and doing screening like the ACEs screening that Lydia talked about before. So there are these 6 guiding principles to a trauma-informed approach. The first one is safety. And throughout the organization, staff and the people they serve, whether children or adults, they feel physically and psychologically safe. The second one is trustworthiness and transparency. The operational decisions are conducted with transparency and the goal of building and maintaining trust with clients and family members, among staff and others involved in the organization. Number 3 is peer support, which is a mutual self-help, right? So you're establishing that safety, which is number 1, and hope, and you're building that trust and enhancing collaboration and utilizing stories and lived experience to promote healing and recovery. We know how important peer support can be in promoting recovery. Number 4 is collaboration and mutuality. The importance is placed on partnering and leveling of the power differences between staff and clients. among organizational staff from across the organization, from administration all the way to clerical staff, demonstrating that healing happens in relationships and the meaningful sharing of power and decision making. Number 5 is empowerment, voice, and choice. Throughout the organization and among clients served, individuals' strengths and experiences are recognized and built upon. Strengths-based approach are very foundational in social work. And so that really leans on that and shared decision-making, choice, and goal setting in the clinical relationship. And number 6 is cultural, historical, and gender issues. So we actively move past cultural stereotypes and biases based on race, ethnicity, sexual orientation, age, etc. And we're responsive to the racial, ethnic, and cultural needs of individuals served. So we talk about this, and when we talk about trauma-informed care, and I worked with Lydia to prepare this presentation, we thought about it in the context of SHARP, right? This was prepared for social workers at SHARP. So anytime that you're trying to do organizational change or implement a new practice, we look at the organization that we're implementing it within. And at SHARP, there is this way of doing business, and it's called the SHARP experience, and I'm sure some of you have heard about it, even if you're not SHARP employees. And so when we look at doing trauma-informed care, it's really helpful to integrate it in with the practices that are already really well-trained and embedded within the organization. So the SHARP experience has a few different things that acknowledge, introduce, duration, explanation. So when you walk into a room, you acknowledge the patient, you introduce yourself, and you provide explanation. And I'll have Lydia jump in to provide more details on some of the SHARP. I was only with SHARP for a short time, but we have behavior standards, and we have a thing called the 5 must-haves, which will come up a little bit later, and pillars of excellence that we'll talk about each of these a little bit more in depth.
So as you all know, with SHARP, we have behavior standards. The attitude is everything, reward and recognition, courteous communication, teamwork, service recovery, zero harm, appearance matters, service excellence, privacy and confidentiality, electronic communication manners, mutual respect, and diversity. And all of these behavior standards relate to working with trauma victims. You know, certainly we don't always know in detail what the patient's been through. Sometimes they'll tell us, sometimes they won't. But we know that we have control over our own behavior, and we can present ourselves with an empathetic ear. And so the question is, which of these standards most closely align with trauma-informed care? And can you think of a patient experience where using behavior standards was also a manner of enacting trauma-informed care? This vignette about Claire is just a brief story. Let me read this to you. Claire has been admitted to hospital following an attempt to take her own life. Staff are concerned that she will either self-harm or attempt suicide again and have set up round-the-clock observation. Claire is naturally private and finds the constant presence of another person during personal care, eating, and sleeping humiliating. The staff members observing Claire do not interact with her much, and rather than feeling supported, Claire feels as though she is being punished. She has few opportunities to talk about the things that led to her feeling suicidal. The constant observation and lack of choice also trigger the feelings associated with memories of unwanted intrusions and lack of privacy in childhood. This leaves Claire feeling more frightened, desperate, and out of control. I'm sure many on this call can relate to this vignette. We changed the title of our one-to-one sitters to safety observers to kind of highlight the importance of their role, with specific requests that the safety observer interact with the patient, and also you know, let the other team members know how that patient is reacting to them, how they're managing with this kind of close supervision. We very openly let the patient know why they have a safety observer at the bedside, especially a patient who is expressing suicidal ideation. So which of our behavior standards should be improved? What would you assess? So in this case, Claire had been admitted to the hospital following an attempt to take her own life. The staff was very concerned about self-harm and perhaps an attempted suicide in the hospital. She felt that we were intrusive and she didn't have any privacy. So explaining to her the purpose was very important. And the constant observation and lack of choice also triggered feelings associated with memories of unwanted intrusions and a lack of privacy in childhood. And as this was communicated from the safety observer to the clinician, we're able to address it head on. So with trauma-informed services on another ward, where care plans are based on a formulation of the person and their context, it is understood that round-the-clock observation can cause long-term harm to a person's recovery. In this ward, another person called Claire still undergoes round-the-clock observation, but staff sit with this Claire to explain why and what their concerns are, as I mentioned earlier. Staff are as interactive as possible. They attempt to validate Claire's feelings of distress and engage in discussion about how to create a plan for ending observations with mutually agreed strategies. We do this every day in our hospital. Partnering rather than enforcing is achieved. This, Claire feels she has hope because she is supported with the things that are important to her. So how do these things match up with the SHARP must-haves? You know, as mentioned earlier, we greet people with a smile and hello and use their name when possible. We take people to where they're going and rather than point or give directions. It helps people feel comfortable in this environment and safe. Use keywords at times. Is there anything else I can do for you? We mention that often leaving a room. Is there anything I can do for you? Not always do I say I have the time, but I do say, is there anything I can do for you? Foster an attitude of gratitude. Send thank you notes to deserving employees. We all work so hard. We notice heroes every single day, and it means so much to people on our team to receive a note of gratitude and thanks. Rounding with reason. I do try to round on the units. Not just to see my staff, but also to learn the culture of the units on the floor and offer sometimes input into some changes that perhaps might make it more comfortable and easier for some of the staff in dealing with patients who are having behavior suggestive of trauma. So the guiding principles, of course, are safety and trustworthiness and transparency, peer support, and mutual self-help. In the last 2 years, the program Care for You has been developed as a peer support program, in that when a staff member is feeling perhaps secondary trauma, that there is a peer support for them and someone to immediately address their concerns and to help in comfort. So collaboration and mutuality, empowerment, voice and choice, and cultural and historical and gender issues. So can you think of other practices in the SHARP experience that align? What else and what's missing? Oh, so this is a cool thing that you did here. So, certainly greeting people with a smile and hello, it's a safety, and it's part of being trustworthy, and taking people where they need to go. Using keywords at times is important, and fostering an attitude of gratitude and rounding with reason. Do you want to do pillars of excellence?
So the pillars of excellence are another part of the SHARP experience, and they really serve as a guiding principle. You see the pillars of excellence for SHARP are quality, safety, service, people, finance, growth, and community. And if you kind of line those up with the trauma-informed care guiding principles, you see that they really align very well, and in addition to the examples that Lydia showed on the last slide. So if we're creating an environment at SHARP that's trauma-informed, it really just kind of permeates the entire organization so that we can do great patient care.
So put it into action. Where do we fit in? Patients reveal their most personal and painful life experiences when we build trusting relationships and encourage open dialogue. The more we understand about the long-term effects of toxic stress due to adverse childhood experiences, the more important it becomes for us to absorb these stories. They form the crux of trauma-informed care. So how do I provide trauma-informed care services? Clarify to the client what to expect in the service being provided. Approach the client in a matter-of-fact yet supportive manner. Respect the client's personal space. Adjust tone and volume of speech to suit the client's level of engagement and degree of comfort in the service being provided. Provide culturally appropriate symbols of safe in the physical environment, including use of preferred names and pronouns. Overcome linguistic barriers by using an interpreter. Only elicit information necessary to determine a history of trauma and the possible extent of traumatic stress symptoms and related disorders. If the client is emotionally responsive when recalling or acknowledging trauma, give the client time to become calm and orient to the present. Provide feedback from the service provided and be aware of possible implications of the service abuse reporting guidelines. Retraumatization, what hurts in the system, policies, procedures, and the way things are done. You know, it's so difficult, I know, for some people. Every time they come in, they're asked to retell their story, and being treated as a number, and procedures that require disrobing, very uncomfortable. Being seen as their label. I've heard staff say, oh, it's that person with mental health problems right over there. He's schizophrenic. No choice in service or treatment. No opportunity to give feedback about their experience with the service delivery. This may be the way things are done, but we're looking to change those things. And looking at the relationship, power, control, subversiveness on the other side is not being seen and heard. Violating trust, failure to ensure emotional safety, non-collaborative, does things for rather than with, and use of punitive treatment, coercive practices, and oppressive language.
There's such a difference there in like how you change the system on the left versus how you change your individual behavior on the right, and looking at where our interventions can be.
Thank you.
And there really are a variety of evidence-based trauma-informed treatment approaches. I know that you all have talked about the PAIR tool in the past, and some of the different evidence-based practices that we know work for from trauma-informed care. Next. There's a few adult-focused models and child-focused models that are utilized specifically.
So looking at the impact of secondary traumatic stress, experience of trauma-related symptoms in a worker as a result of witnessing the trauma, adversity of another, typically quick in the onset. The example might be shortly after interviewing a victim of physical abuse, a nurse begins to have a headache and is unable to concentrate, which results in her leaving her shift early. Vicarious trauma, development of negative changes in work world view as a result of the cumulative impact of witnessing trauma, adversity over time. And the example is a child welfare worker finds herself not wanting to let her daughter out of her sight after taking the position 6 months prior because she feels the world is not safe for her children. Compassion fatigue, experiencing the combination of secondary traumatic stress and vicarious trauma and or burnout. Vicarious resilience, positive meaning making and shift of the worker's experience as a result of witnessing the resilience of others. A teacher reaffirms the reason he decided to go into education after witnessing one of his students excel in his classroom despite the struggles she had at the beginning of the year due to family adversity. An example of vicarious post-traumatic growth, the development of positive changes and growth in the worker's worldview as a result of witnessing the post-traumatic growth of others. A counselor may reflect on how he has become more compassionate and self-aware over the years as a result of witnessing the growth of his clients. Our last vignette is about Ted. Ted has been admitted to a psychiatric hospital many times, hearing voices that threatened to hurt him. During his early admission, staff told Ted that the voices were all in his head and that he had nothing to be afraid of. Although this was true, Ted did not find it soothing, but instead became more anxious as he felt he was not being listened to or believed. Ted worried that if these awful thoughts came from his own mind, then he must be either crazy or an evil person. Ted became more afraid afraid of the contents of his mind. Recently, Ted's hospital has trained its staff in trauma-informed approaches and trauma responses. When Ted explains what he is experiencing, the staff take the time to listen to him and explore his fears. Ted is asked what sense he makes out of hearing voices and about any previous times that he was able to manage the voices. Staff also asked whether Ted is aware of the Hearing Voices Network. In taking this approach, staff do not argue about the reality, but acknowledge Ted's emotional distress and attend to it. This has the same purpose of letting Ted know that he is safe, but Ted experiences it as a gentle and validating because he feels listened to. It also means that Ted has built strong relationships with many staff members and consequently feels well supported. Staff help Ted to understand that his reactions are common in people with his history, and they find ways of helping him notice the voices are triggered by particular social stressors. He's beginning to explore how triggers link to his past. So we just had a brief quiz after this trauma-informed care module. And of course, the answers are all highlighted here for you. So research shows that adverse childhood experiences can affect mental well-being, shorten life expectancy, result in negative health outcomes, all of the above, of course. And which of the following is not a guiding principle of trauma-informed care, a nurturing and caring environment? And trauma-informed care is only used once a trauma history has been established, and of course that is false. Asking the patient to continually recount their trauma history, an example of retraumatization, which is true, and the 5 must-haves of the SHARP experience align with trauma-informed care, true. So trauma-informed approach for organizations incorporates all of the following elements except relating to the patient's experience yourself. That's the end of our presentation. We have certainly time for some questions or comments.
I have a question for either of you or maybe both of you. The principles of trauma-informed care, number 4 and 5 seem to have a lot of overlap. Can you help distinguish those a little bit more clearly?
I'm happy to so Lydia, I don't know if you want to go all the way back some slides to it. It's a little bit back, but so the number 4, collaboration and mutuality, and then number 5 is empowerment, voice, and choice. I think of the collaboration and mutuality of almost like being less of the power differential. You see it a lot with like the white coat type of idea, and that there's just such a power differential that somebody's not going to be in the same space, versus empowerment, voice, and choice is bringing the client and the individual, empowering them and bringing them up, and allowing them the opportunity to have choice and to have decision making, and to feel empowered in their own self. So it's almost like what happens with the client, and then what happens with kind of leveling the playing field and removing power differentials. I think it's the difference.
Thank you.
I think the example earlier of the safety observer speaks to that issue as well, in that, we're including them. Most of them are, aides, health aides, and really have not had the background in education that some of us have had. So including them in the care of the patient, incorporating some of their observations and interventions, I think can be really powerful and healing for the patient.
Yeah, thank you for that. Concrete examples definitely help. I just wanted to remind everyone, if you haven't yet, please fill out the attendance form and the thank you note. The links are in the chat. Do we have any other questions for Lydia and Amanda?
Yeah, this is Scotty Nicholas. Can I jump in for a second?
Yeah.
Can you hear me? Okay.
Yeah.
Yeah.
First, thank you very much. This is an amazing presentation and very timely. I would like you to maybe say a word or two on how the current state we're in is affecting or actually pushing us to really consider trauma-informed care even in a bigger lens, because now it's becoming full circle, and the traumatized people are our staff with COVID and everything. So more than ever, trauma-informed care should be really a guiding principle for our organization. And just wanted to kind of bring up that angle. Thank you.
Yeah.
Thank you, Dr. Nicholas. So very important. I mean, every day I hear from my team about the additional stress that they feel. You know, being at work sometimes, fearing that, you know, they could be exposed to COVID even though they're vaccinated, taking that home to their families, you know, seeing patients die every day. Like, you know, this summer was just horrible, and last winter. You know, all those things are very traumatic for our staff. And understanding that, you know, some people are reporting that they're having problems sleeping and maybe overeating or having memory issues. All of those are sometimes related to the recent trauma. One of my team members last week attended a really serious trauma of a young woman, pretty much her age. And she called and said, you know, I need to leave, and I need a break. You know, understanding that, you know, sometimes we have to make exceptions. You know, leaving the job is not something most people choose to do, but sometimes that is important for our survival. You know, trying not to take that home to the family, talking it out. Again, I think that the Care for You program, the EAP program we have in SHARP, all of those are peer support programs for our team members. And we need to remember to offer those. I think people forget that internally we have these resources to help our team cope with what we can't change right now. So thank you.
And if your healthcare system doesn't have those type of resources, it's time to reach out to your leadership teams and see what you can do to create that mutuality and a trauma-informed organization. I wanted to put in the chat window here, because Dr. Nicholas brought up that, you know, this is a very tangible thing. SHARP is working on a trauma-informed care continuing ed series that is going to be free to the public. So please take advantage of that and share it with your colleagues. And we'll be announcing that as soon as it's ready. But I put in the chat window the modules that we're preparing. One is on PTSD, one's on trauma-informed care principles, which we had a really wonderful brief introduction to trauma-informed care skills for clinicians, the PAIR tool that we've talked about a little bit tonight, and ACE scores and vicarious trauma. So all of those should help you both in supporting your patients, but also in supporting your team members as they talked about tonight. Does anyone else have any other questions?
So Amy, we'll make this PowerPoint available
Sure.
to the people who attended. There's a lot of words in here, so I think that would be a nice thing to provide.
Right, and we're also going to provide the recording on our YouTube channel for everyone. So those that weren't able to attend with us tonight will be able to see that. So.
And there are source links and citations at the bottom of a lot of the slides too, if you're interested in learning more or digging into the research that supports some of the points on the slides. That's easy access to the citations or where the information came from.
Thank you for that. Thanks. Does anyone have any other questions before we let them go? We really appreciate your presentation, and if you haven't yet, please sign the thank you note for our guest speakers tonight, and your attendance form would be appreciated too. Thanks.
Thank you very much for attending.
Thanks. You have a wonderful night.
Thank you.